Hey there. Oh, we had a little problem here on this side. Let's see if we can do another live on Instagram. Hey, oh gosh, something's not working right. I am trying. Give me 1 second here. Tell you what, I'm going to log out right here and we're going to start again in 1 second. Okay. Thank you. Okay. Fink and Friends. We had a little problem there. Okay. This ought to work now. Okay. Hey there. Did it work? Are you there? Fink and Friends. Friendship. Fink and Friends. Now, that was the strangest thing I've ever seen. Okay. Good afternoon. And boom, now it's live. We had a little technical difficulty there at the last minute, but um, thank you so much for being here. Good afternoon. It is 4 o'clock. Actually, by now it's 2 minutes after 4, and you are in the right place. Same place we are every Tuesday evening at this time. It is Fertility with Fink and Friends. I am Fink. You are Friends, live from Colorado Springs. My name is Dr. Randy Fink, and I'm the clinical director of IVF services here at CNY Fertility, Colorado. So nice to see everybody. Let's see who we've got joining. Hey, Shaden, thanks for being here. Amy Jenkins is with us, as is my beautiful mother and father in Mobile, Alabama. Thanks for being here. Hi to Mariah, Jamie, Kayla, Midgie, Miss Y. Gracie. Thanks for being here. Roz Johnson, you are number one on my Instagram over here. Thanks for being number one. Meanwhile, on Facebook over here, we've got Liz Fisher, Forsaken Phoenix. Nice to see you gearing up for your FET in Sarasota. That's exciting. Marcia is here as well. And let's see, that's also, we've got LinkedIn and Facebook here in the middle. And on this side is CNY's Instagram. And let's see who we have over here. Jenny is number one. Thanks for being number one. And Rosa, nice to see you as always. Jennifer Kelsey, Lyric the Poet. Nice to see you here as well. Siciliana Melissa, always a pleasure. Sweta Bandaru, Nadia Healing Arts. I like it. Hi, Brittany, AZ Signatures, AZ Sunshine. J. Rebecca Kennedy. Thanks for being here. We've got Laura. Noodles for life. I like that, Noodles. And the list goes on there. Thanks to everybody for being here this afternoon. How's your Tuesday? How's your weekend? How's your week going so far? It has been an interesting week over here, and it's always great to see some old friends joining, to see friends showing up here in the clinic, and most importantly, also we love to get those pictures of your kids and those positive pregnancy tests. Gosh, even pictures of positive pregnancy tests is enough to make us all very happy. What's happening in your world? I hope that it is just as beautiful in here as it is out there. Here in Colorado, it's about 80 degrees, and it's always really very strange when it's 80 degrees here and 120 degrees in the places next door. So you're in the right spot. This is the place where we settle in and talk about the things that are important to each of us. So see if you can throw your questions my way. I'm going to do my doggone best to get them answered. And so let's dive right in. Let's start there with Liz. Liz says, I'm in Colorado Springs for my first FET tomorrow, hoping and praying all goes well and we get our little miracle. Me too. Any suggestions on how to make PIO injections a little more bearable? The injection itself has been painless for me, but the days after, I'm sore. So I think all of our friends who have been through this process before can tell you that PIO injections, well, and I'll tell you in my own experience, it is the thing that probably people like least about the IVF process, is having to do the progesterone in oil injections. So that's why one of my suggestions is doing a modified natural frozen embryo transfer instead of a medicated cycle. And in that situation, your body is making your own progesterone, so therefore you don't have to do the PIO shot. Now, if you're on a medicated cycle, you really do need to do the PIO shot. And there are some people that say, well, I'm going to do that medicated cycle, but I just want to use the vaginal progesterone. I've decided I'm not going to do the injection. And I would tell you, okay, you certainly can do that, but the data on that is very, very clear. And that is that the outcomes are not nearly as good. The outcomes, the pregnancy rate and the birth rate is extremely low in that scenario. So my feeling is don't do that. If you're going to do a medicated cycle, do the PIO, but maybe consider doing a natural cycle or a modified natural cycle, which is where we let your body lead with the hormones. And we're just checking those numbers, giving you a little extra if you need it. But that way you don't have to do the shot. There is a company that is called Dandy, and I'm looking for a website here. Actually, if you will look at Brandis Montez, who's our nurse practitioner here, look at her Instagram, Brandis Courtney. I believe there is a link there for the Dandy. And the Dandy system is something that really helps you to find the right spot, to find the exact spot, to help to minimize some of the discomfort associated with those injections. You can alternate heat and cold before and after, and it's really a nice little system. So I would say please look at that Dandy device, and I believe Brandis has a link over there. Let's see, Forsaken Phoenix. We said, hi, going to your FET tomorrow. Hi to Sally in Trinidad, I believe. Sarah McCloskey says, I have a question. Lay it on me. I had an ablation about 5 years ago, but I want another baby. Would that still be possible? Okay, so let's talk about that. An endometrial ablation is a minimally invasive treatment that we use for treating heavy menstrual bleeding. So it used to be that if you went into the gynecologist's office and you said you were done with your childbearing and your periods were a problem because they were very heavy, the doctor might very well say, well, you're not using that uterus for anything. Let's take it out. Let's do a hysterectomy. The endometrial ablation was something that was designed to replace the hysterectomy. It is a treatment whereby we can basically give the lining of the uterus a sunburn. And you know what happens if you get a sunburn on your shoulder? That skin peels and then it grows back again. Well, if you give a sunburn to the lining of the uterus, that skin peels. And then in most cases, it doesn't grow back. And the result from that is that a large proportion of women will stop having periods entirely. They say the goal of the endometrial ablation is to try to give you a normal period. But in fact, with most type of ablations, people will just kind of stop having a period. And when you're in a situation where your period is running your life, where you're worried about where you're going to be when that period comes, because it's going to be a disaster, it's going to be a murder scene. To go from that to when I say, well, when was your last period? You say, I think I had some spotting a few months ago. Endometrial ablation is a wonderful, wonderful treatment. It takes about 2 minutes to do under a little anesthesia. There are some different types of ablation, but the most common one is called a Novasure, Novasure, a Novasure endometrial ablation. And with that one, it really is very significantly damaging the lining of the uterus. There are some other types of ablations that are not as effective, that don't treat as deeply. So I think pretty much Sarah, the question is, well, do you still have periods? Most of us would be very uncomfortable transferring a pregnancy into a uterus that has had an endometrial ablation. because it would be an extremely high risk pregnancy. First of all, even if the pregnancy were to be able to implant, which would require some normal endometrium on the inside, if it did implant, then in all probability there's a very high risk for abnormal placentas and all kinds of other things. So personally, I would be very uncomfortable doing that, because that really has the potential of putting your life at risk. Now, you could 100% go through IVF, use your eggs, partner sperm, create embryos, and place those embryos into a gestational carrier so that somebody else could carry the pregnancy for you. And that's what most people would do, because even investigating the probability or the possibilities of being able to carry a pregnancy after an ablation is a very scary thing. So in general, I would say probably don't recommend it. Now, I say that, but of course, there are scenarios. There are some situations where people had a type of ablation that really barely did much of anything. Maybe it didn't even change your periods very much. There have been a number of different technologies for endometrial ablation over the years, and I've used a bunch of them myself. Not on me, but to help people with period problems. Some of them work better than others. So I would say, if you did that ablation, it really didn't change your period at all, and you're still kind of having normal periods, then there's a possibility. The other thing that happens though after the ablation, Sarah, is that it causes a great deal of scarring inside the uterine cavity. So if you've had a novissure ablation, there's a high probability that we can't even access that cavity anymore, that the cavity becomes really scarred shut. Pardon me. And there's just no way to kind of get inside. So that's my 2 cents worth about that. Let's see. Andre, hello from Los Angeles. And Midgie, thank you for being here. How long do you recommend being off semaglutide before a frozen embryo transfer? Comes from Miss Y. Gracie. So the current recommendation is that you're off of a GLP-1 agonist like semaglutide or so Ozempic basically, or Mounjaro, 2 months prior to conceiving. So 2 months before an FET. Now, I do think that at some point those recommendations will change, because there are a lot of people who are getting pregnant on these medications. As you know, I'm sure you've read about that stuff too. But 2 months is the current recommendation, just because they don't really know what hasn't been researched very well, what kinds of effect these medications can have on pregnancy. Nurses, I think all I see is Marie there. It's a little out of my focus. Sorry about that. Does a progesterone of 12.5 on transfer day mean I'm out of this cycle? No, if you're doing I presume you're talking about doing a medicated cycle. No, that's okay. Now, if you're trying to do a fresh transfer and your progesterone was 12.5, then that means no, we would not want to do that. Your window of implantation is closed. But if we're giving you all that progesterone, I think you'll probably be okay. The queen of all, phenomenal doll. Hey, nice to see you as well. Rosa says, 42 years old. I have a low AMH and an endometrioma, or a collection of endometriosis on my ovary. It's almost 5 centimeters. Never had pain. Before embryo transfer, do I just suppress with Orilissa or go in for the surgery? Is Orilissa as effective as surgery? Okay, so what we're talking about here is endometriosis. We know that endometriosis can affect fertility in a number of different ways. So it can affect ovarian reserve. It can affect egg quality. Mechanically, it can cause scarring and affect things like the fallopian tubes and where the ovaries are and so forth. From a transfer standpoint, endometriosis confuses the way the brain talks to the uterus. How does it do that? It creates a marker, an inflammatory protein inside the uterine cavity that's known as BCL6. Well, BCL6 we can test for. with a test known as Receptiva. And you've heard me talk about Receptiva before, I'm sure. I'm a big fan of the Receptiva test because I think, it allows people to get a diagnosis of endometriosis without having to have surgery. I am not a big believer in laparoscopic surgery for reasons that are solely for fertility. Now, if you have pain, if you've got other things going on, if you've got a big fluid-filled tube, then yeah, laparoscopy, of course, is a great idea. But I don't generally recommend diagnostic laparoscopy to try to find endometriosis. Why not? Because I can do a 10-second non-invasive biopsy of the uterine lining called Receptiva that will tell me whether you are expressing that protein called BCL6. That means endometriosis, very highly correlated with endometriosis. So, what does it mean if you're expressing BCL6? It means that, well, okay, if we knew that we had a euploid embryo or a chromosomally normal embryo, that embryo gives you a 65% probability of pregnancy, right? That's pretty damn good. That's best numbers that we can hope for in IVF. But if you're expressing BCL6, that 65% number drops down to really about 10%. I think it's actually 12.5% to be precise. So that's a significant decrease. And so how do we treat that? We suppress you. We give you medication. Or then at that point, you could have surgery to see if you could find some endometriosis and excise it to try to get rid of it. But simply speaking, if you wanted to do this without surgery, you could do it all with Receptiva and medication. Now, the question is, if you've got that 5 centimeter endometrioma, which is, that's about, that size, that's pretty big. Is it worth having surgery for that? You don't have pain. When things get to be about 5 centimeters, we start thinking, well, then you worry about them twisting on themselves, which is called an ovarian torsion. And that's something that, you might think about having surgery for. But the truth is that everyone with endometriosis isn't necessarily expressing the BCL6 inflammatory protein. So it's possible that you have endometriosis, your BCL6 is negative. It's all is the converse true, that you have endometriosis or your BCL6 is positive and you don't have endometriosis? No, it's pretty highly correlated there. So what does that all mean? Well, it means that, when we treat you with the medication, really all we're trying to do, if you take 60 days of Orilissa, Rosa, and do I expect that to make any difference at all on your 4.7 centimeter endometrioma? No, I don't think it's going to change that at all. But what it probably will do is shut down the BCL6 that's in the lining of your uterus, and then hopefully you can get pregnant. Now, again, close to 5 centimeters, do you want to think about removing that? There may be other reasons to go and remove it, but we do know that when you have surgery to remove cysts in the ovary, almost always that will result in a decrease of your AMH, your ovarian reserve. So generally speaking, folks who come in to me with endometriosis, we say, don't have surgery before you don't have surgery before you get your eggs. We can stimulate you, we can get your eggs, make as many embryos as we can, and then go have surgery because the AMH is going to go down after that. Hope that makes sense. Hey, DeGay, you will be here for transfer next week, Monday the 29th. I will look forward to it. Jenny says, how much L-arginine should we take daily? Okay, so L-arginine is one of those things that is on the supplement list for embryo transfer. I absolutely positively do not recommend L-arginine for egg quality because the data shows us that it has a negative impact on egg quality. So please don't take L-arginine. There is a common supplement that is sometimes recommended for people who are wanting to get pregnant that's called Serovital. Serovital is said to increase your growth hormone levels. And as you may know, we give you growth hormone sometimes to try to improve your egg quality. Serovital is a vitamin, but one of Serovital's, it has not been studied in pregnancy and infertility. And one of its major ingredients is L-arginine. So I don't recommend Serovital to you for that reason. However, it is on the list of the evidence-based protocol for embryo transfer. What can you do about the horrible taste? So I've seen L-arginine supplied in a couple of different ways. I've seen it supplied in a powder form that you mix up in a liquid and you try to drink it. I couldn't choke that down if I wanted to. Any of those things that you have to mix with liquid and then try to drink them, I think are noxious. I swear, if it's not a Coca-Cola, I probably am not all that interested in it. And I'm really, you should take a look. I've had enough Coca-Cola. Um, the capsules, pills. I haven't taken it myself, so I don't know about the taste. But for people who take things that tend to not taste good and they tend to burp back up, you want to make sure that you're taking them with some kind of liquid, preferably something that has a little acid in it. So orange juice is a good thought. If you take, let's say, you take your fish oil with a Coke. You know that you're going to be burping after that Coke and you're going to be burping up some fish oil. So even the kind that says that it's odorless or burpless, you'll still get some of that. And it's some of these fish oils, you get it burped back up one time and you will never take it again because you will be like, how did I let that go down my throat if I had any idea that what was going to be coming back up there? So I think it's definitely good to get the burpless kind. But as far as L-arginine, get something that doesn't make you burp. Water tends to, people do tend to kind of, because you're swallowing some air, and so you're going to burp some of that back up anyway. And water tends to, since it's tasteless, doesn't cover up any flavors. Sometimes something with a little acid, like some orange juice, even apple juice, may alter the flavor of something that you're swallowing, medication or supplement wise, that gives you the yuckies. Let's see what we got here. Jessica says it's 10 weeks pregnant. That's awesome, Jess. It was so bittersweet doing my last PIO last night. When does the placenta start taking over? The placenta takes over for making progesterone at about 9 weeks of pregnancy. So we usually give you some extra progesterone for an extra week, just as a little bit of overlap there as a safety margin. But now you are one full force functioning unit there, Jessica. Congratulations. Can't wait to see those pictures. That is awesome. And for graduating from PIO. Jessica says, heat the site prior and after and massage it. That's talking about PIO pain. Thoughts on transferring after or during a cold? Well, when you have an upper respiratory infection, people do get pregnant anyway. I would certainly say that in a perfect world, don't do a transfer when you're sick. But guess what? It's not a perfect world, because maybe you're doing a medicated cycle. Maybe you're not. Maybe you're doing a natural cycle. You've taken little medication. You've done some monitoring. You made some travel plans, and then you get a cold. Are you going to cancel? Your transfer because you got that little cold? I would say no. I wouldn't do that. But things that are more, in a perfect world, you wouldn't. But it's not a perfect world. Things that are a little stronger or a little bit more significant. So if you have COVID, I don't recommend you do a transfer if you have COVID. I don't recommend you do a transfer if you have acute influenza. If you have a shingles outbreak, all these things are very activating to the immune system, and just, may increase the probability that your immune system tries to do things with your pregnancy that you don't want it to do. So just my 2 cents worth there. I have not seen any data that talks about, outcomes of embryo transfer for people who have an upper respiratory tract infection. Ours is not such a fragile species that, I've had people say, Gosh, oh my God, I'm so worried. I'm so worried. I did my embryo transfer, but then I took a warm, not hot, just a warm shower, and maybe that was too hot. Um, we're not that fragile a species. You can take a shower. You can do kind of most normal things. There are a few things that you're not supposed to do when you're pregnant. Do you know what they are? You are not supposed to have raw things. So if you like sushi, it's cooked sushi. You are not supposed to have deli meat. Deli meat. And gosh, I'm having deja vu. I think I talked about this last week. Deli meat um, can be infected with a bacteria that's called listeria. And in fact, I've been seeing there's a listeria outbreak in the United States in the last, probably week or two. And so you want to heat it. If it's hot enough, put a piece of cheese on it. If it's hot enough to melt the cheese, then it's hot enough to probably kill the listeria. But really, that's all you're kind of supposed to not do. So I think you're okay if you have a cold, but the world's not perfect. What's the difference between a modified natural and a medicated FET? This comes from Pretty Key. So a modified natural is where we are letting you and actually getting you to ovulate. So in your normal menstrual cycle, when you ovulate, what happens? Your ovary produces an egg. Your ovary releases that egg. That egg goes out, waits for sperm to come and fertilize it. When sperm fertilizes it, you're pregnant. Well, in a transfer cycle, hormonally, what's happened as you make that egg, we give you a little medication, some letrozole usually, to make sure that your ovary does, in fact, produce a good egg. That egg is lined by some cells that are called granulosa cells. Granulosa cells make estrogen. That's where your estrogen comes from. And your estrogen builds up your uterine lining. That uterine lining is your baby blanket. It is it is the place where your embryo is going to implant. It is your little built-in bassinet. So that's what the estrogen does. As that follicle gets bigger and bigger, it makes more and more estrogen until we see that it reaches a mature size, and then we can tell your ovary, get ready and release that egg. When the ovary releases the egg, then you start making your own progesterone. And since you're making your own progesterone, that's why you don't have to do the progesterone in oil shot. Woohoo! No shot. If so that's a modified natural. In a natural cycle, we don't have to give you the ovulation induction. Sometimes we like to do that because it actually can help with the uterine lining. It improves the lining somewhat. So I think a modified natural is really the way to go. But a fully natural cycle is where you just make an egg and ovulate it on your own. We don't have to do anything with it. To trigger the ovulation just gives you a little bit more. It gives you a little bit more control over the logistics. But as opposed to a medicated cycle where we're shutting down everything in your body, we're shutting down your body's ability to make those hormones, and we are providing them to you pharmaceutically. And that comes in the form of estrogen, pills that you take orally and vaginally. That comes from progesterone in oil that you're giving yourself in the form of an injection, and also some vaginal progesterone as well. So that's a medicated cycle. And the difference is, they're at least equivalent, but there's some studies that show the modified natural has a little higher success rate. I think it's easier on your body. And frankly, it just makes sense to me because your body is making all those hormones. Why not, you do it anyway every month. So why can't we just, let your body contribute to the program? Now, the alternative is, or the caveat there is that, well, some people just don't have regular cycles. Some people don't make the hormones, and sometimes for whatever reason we need to control every variable, and that's what the medicated cycle does. Let's see here. Kelsey says, hoping to do my FET with you next month. Awesome. This cycle, my lining was 12 and homogeneous, and I've never had it not trilaminar before. Is there a reason why it would have been homogeneous? So usually what that means is that it has to do, so you're talking about the way the endometrium, the way the lining looks when you do an ultrasound. And typically that has to do with kind of the timing on when you're looking at it, because a trilaminar lining, trilaminar, 3 layers, and that's basically the top layer, the bottom layer, and the third layer is actually the interface between them. So you're seeing 3 layers there by ultrasound. That typically just means that it's adequately estrogenized. So my first thing, Kelsey, would be to say it may just have to do sort of with the timing. Let's see. Better with a Batty says supplements you recommend having on hand before IVF. So I wrote a book on that very subject, and you can access that at my link tree. Link tree is linktr.ee/Randy Fink MD. Or if you go to my Instagram, which is Randy Fink MD, it is the link that's in the bio. The book is called The Vitamin Victory, and that has the evidence-based protocol for IVF, for fertility in general, for diminished ovarian reserve, for embryo transfer, for sperm quality. Kind of goes through everything and makes it pretty easy for you. Let's see. No one is responding via the portal. Okay, so you got to leave a mess. You got to make sure that you're sending it to the correct people. And so if you're a global patient, you generally send that to the global team. You may also try, if you're not getting a response, send it to the nursing team at the place where you are intending to do your procedure. So what's happened is that at CNY, there's been a little bit of a changeover. They've restructured the way the global team is managing people, and so there may still be some little hiccups with that. But people are usually very good about answering the portal. So if you're not getting the response from global, you need just go directly to the location. So if you're doing it in Sarasota, go to Sarasota Nursing, for example. Let's see here. I think we answered that one. Hi, Shida. How does Lupron work? How soon after that can one start a second stim? Okay, so Lupron as a trigger shot, what Lupron is doing normally, the way hormones talk to the pituitary gland, Lupron changes the way hormones talk to the pituitary gland. That's an easy way to do it. But if you have done a Lupron stim, a Lupron trigger and or an HCG trigger, well, then you do your egg retrieval 35 hours after the trigger, and typically then about 10 days later, you will have your period and you can start your next stim. Then that's what we call a back-to-back cycle or a stacked cycle. And I very strongly recommend a back-to-back cycle because the medication that you're using in the first cycle will continue to help you recruit eggs in the second cycle and so on. We oftentimes see improving quantity of eggs, but we almost always see improving quality of eggs. Now, the other option there is something that is called a duostim or a luteal phase start. This was something originally built for folks with cancer. So let's say that you knew that you had to start your chemotherapy on such and such a date, and you needed to, you had a hard stop by the time you had to be done. But we know that we wanted to get as many eggs as we could because the chemo you were going to use is toxic to the ovaries. So we want to get those eggs from you ASAP. Well, a duostim allows us to, like 4 days after doing your egg retrieval, we can start another stimulation. Typically, you get about 25% fewer eggs in a duostim. There are some circumstances when, particularly in poor responders or people with very low ovarian reserve, where a duostim may be beneficial. But in my opinion, those are relatively few and far between. Occasionally, I'll recommend it, but in general, I try not to. So you can start your second stim really when you get your next period, which will be about 10 days after your retrieval. And that's a back-to-back cycle. Hello, Amber Vince. Thank you for being here. Let's see. Siciliana Melissa says, I'm almost 11 weeks. When do I stop taking L-arginine and the other supplements started for my FET? I'm so glad to hear that you are pregnant. You can stop those now. So really the only thing that you need to do during ongoing pregnancy is your prenatal vitamin and your fish oil. So nothing that you've taken. So the vitamin D, the vitamin E, the CoQ10, the L-arginine, none of that harms anything. So don't worry, but you just don't need to be on them anymore. So fish oil, because that omega-3 is very good for the baby's developing brain and eye visual function and brain function, as well as just your prenatal. So congratulations, Ceciliana. That is good news. Bubbles says I'm on 60 days of Oralissa. When I am done with that, how long after would I have a transfer? So what we know is that when you're suppressing with that Oralissa medication, the best numbers for transferring happen really as soon as you stop the Oralissa. So I would go directly from Oralissa into a transfer cycle. It is usually easiest to do a medicated cycle in that scenario, because sometimes when we have suppressed the pituitary gland and the hormone function, it may take a little time for that to kind of get back to normal. Many people will do a modified natural going right out of Oralissa. I certainly would not do a regular natural. And in my opinion, I think it's just easier to do a medicated cycle in that scenario. But I would do it right after go from day 60 of Oralissa right into your medicated cycle. And that's when the outcomes are the best. Mariana says, what tests do you recommend after a miscarriage? Well, I'm so sorry to hear that you had a miscarriage. And I see that Marcia is here as well, asking about a chemical pregnancy and then had a DNC in April. Does a DNC have a positive effect on trying to conceive within the following few months? Okay, so let's see if we can answer that. So first of all, most miscarriages happen as a result of chromosomal issues with the pregnancy. And a chromosomal issue is something that's genetic. It can arise from the sperm. More often than not, it results from the egg, because the sperm that he produces today were manufactured in his body 3 months ago, whereas the egg has been in your ovary since the time you were born, actually, when you were in utero. So most of the time, so as we mature, the DNA, the genetic material in these eggs becomes less stable, and that can result in, unfortunately, creating an embryo that doesn't have the potential to continue to grow because it's not normal. It's a very sad thing. It is the loss of a member of a family. There are many people who experience miscarriage for whom their friends or with whom their friends just don't understand what they're going through. It's a very hard time. Some people handle it, very well. Some people, it's a much bigger challenge, and you really do have to give yourself the opportunity to grieve. It is the loss of a family member. It's a family member that you didn't know personally yet, that you didn't have the chance to, and is really because there was something wrong, generally speaking, with that pregnancy. So I like to think that those pregnancies move on maybe to a little happier place. There's no specific testing. We'd like to know that your beta HCG, your pregnancy test, goes back down to 0. Like to know that your blood count is normal. Now, folks who have recurrent pregnancy loss, that is, people who will keep losing pregnancies, that's a different story. There's some different kinds of tests that we do there. But as far as the chemical pregnancy, a chemical pregnancy is where, rather than developing a pregnancy inside the uterus that we can see with the ultrasound, it is merely just a number that the pregnancy test starts to go up, and then it starts to go back down before the pregnancy has become visible or diagnosed as an intrauterine pregnancy. You had a DNC. Does a DNC have positive effects on trying to conceive within the following few months? No, it really shouldn't make too much of a difference. I guess what happened there, well, I'm not quite sure, Marcia, how that all sort of went down. But a DNC, when possible, we try to not do it so that we don't have to be instrumenting the uterine cavity and that precious endometrium. But sometimes it's necessary, and sometimes it's necessarily medically, sometimes it's necessary emotionally, that it's just the right choice for you. So I would never criticize that choice if that's the right choice for you, but shouldn't have an effect on your ability to conceive in the coming months. Generally, I like you to have your first normal period again before you try to conceive after that miscarriage, because that does decrease the risk for subsequent pregnancy loss. Um, Liz, if you have a history of low progesterone, would anything besides a medicated cycle be good? Yes, even a modified natural will work for you because we're still checking the hormone levels. And even in a modified natural, so we say natural cycle. Natural doesn't mean, okay, call us when you have a birthday party, for your kid. It means, well, all right, we're just letting your own hormones take the lead. And so as a result, we're checking the levels anyway. And if you need more hormone, we will give you more hormone. So even with that history of low progesterone, and I hear about that low progesterone thing a lot, that is not a contraindication or a reason not to do a modified natural, because we absolutely control for that. What can cause a subchorionic hemorrhage? Things to avoid or help if you've had one. So, a subchorionic hemorrhage is basically a bruise that is collected beneath the placenta. So, generally, what happens there? You get pregnant, you develop a clinical intrauterine pregnancy. And what do we say that means? That means you have an ultrasound and we see that the pregnancy is inside the uterus. Now, sometimes a subchorionic hemorrhage is something that's just diagnosed by ultrasound. Sometimes maybe you have a bleed, you have some bleeding. And so you go to the hospital or you go to your doctor's office. I've had some bleeding, and they do an ultrasound and they show this collection of blood that's sitting underneath the placenta. Well, that's a subchorionic hemorrhage, a bruise like any other. So if you come along here and punch me in the arm and I get a bruise there, what happens to that bruise? Well, it turns black and blue, and then it turns sort of yellow brown, and then eventually it kind of fades and goes away. Same thing is happening inside the uterine cavity. That bruise is trying to go away, but sometimes rather than just being reabsorbed into your system, some of it wants to escape out the door, and that's why you have some bleeding. 50%. 50%, one out of every two pregnancies in the first trimester will have some cramping and bleeding. So that subchorionic hemorrhage is a very common finding. The real question arises as to, well, okay, I'm on Lovenox as part of one of the immune protocols. So what do I do about that? Do I stay on the Lovenox? Lovenox is a blood thinner. Is it causing me to bleed? Did it cause my subchorionic hemorrhage? No, almost certainly it did not. It just happened because the placenta is moving. As the placenta moves, as the uterus grows, it can just shear off a little space underneath, and that's really what causes it. I say if it's a small subchorionic hemorrhage, you do not need to stop the Lovenox because, again, very, very common stuff. If it's a large subchorionic hemorrhage, then sometimes we do say maybe we want to stop your Lovenox. A special hello to Angela in Minnesota. Thank you for being here this afternoon. Rosa says, thank you for being so great and kind. Oh, Rosa, stop. Okay, one more time. Just one more time. Hey to Brooke. Thank you. Good afternoon. Get like blessed. Let's see. Why can't CNY adjust the TSH medication instead of going elsewhere? Well, normally I do adjust the TSH medication. Now, if you see a medical endocrinologist, for instance, let's say you have some complicated thyroid history, then we may say, okay, bring that back to your endocrinologist because they're really sort of experts in that. But if we started you on medication, or yeah, I'm not really sure there. Looks like it comes from Jan and Telato. Normally, I do adjust medication, so there must kind of be more to the story there. Noodles for life. Love your glasses, Dr. Fink. Oh, you mean these old things? I just put them on, Yeah. If you've been watching over these last few weeks, I got a bunch of new pairs of glasses because you got to dress it up somehow. Yeah, you can't see my underwear. You don't want to see my underwear. You can't, I can't, I don't wear big necklaces, and I got a watch, but that's it. Really, it's socks and glasses. When you wear PJs to work every day, that's what you can do. So, yep. Thank you very much. I appreciate the compliment. Maria King, when should you stop that L-arginine after the frozen embryo transfer? With your positive pregnancy test is when I would stop. Let's see, we talked about natural versus medicated. How successful are frozen 3-day transfers? This comes from AZ Sunshine. Well, so the thing about a day 3 transfer, and this is something that we do talk about a lot, and I want everybody to kind of hear it, because I want you to understand what the thinking is about this and how different people think of it in different ways. But first, let me say 46 minutes past the hour. We'll be here for about another 15 minutes or so. Fertility with Fink and Friends. And I am Fink. You are friends. So glad to be with you like every Tuesday afternoon. Okay. So a blastocyst is known is a day 5 embryo. If your embryo grows, typically day 5, sometimes day 6, sometimes even day 7. If your embryo grows to the point of being a blastocyst, then we know it has a higher probability of being able to get you pregnant. Right? So that's a good thing. Yeah, it's definitely a good thing. But if you're limited in the number of embryos, we will usually suggest that you stop on day 3, that you transfer on day 3, or that you freeze on day 3, which is what's called a cleavage stage embryo. And why is that? Because all the time, personally, I feel like I would rather see an embryo going inside of you than an embryo potentially dying in the lab, because we know that all day 3 embryos will not be able to grow into blasts. If we have all day 3 embryos, we are going to be doing more unsuccessful transfers. But our body has DNA repair mechanisms. We may be able to repair an embryo that is somehow chromosomally normal, or partially chromosomally normal, or even entirely chromosomally normal. Nobody really knows. So if you're limited in the number, I would much rather see that embryo going in you where it has a chance than potentially not growing in the lab. However, if you have enough embryos, then sure, grow them out to blast, because then you're going to let nature help to select some of those embryos that have a higher probability of getting you pregnant. I hope that makes sense. So what are the chances of a day 3 embryo working? Well, it really depends. Often it kind of depends on age, on how old you are. But a day 3 embryo probably has about, and again, depending on age, about half of the probability of working, as does a blastocyst. So, what does that mean? Well, what's the probability of it becoming a blastocyst? If you're 44 and you have an untested blast, that gives you maybe about a 2% probability of getting pregnant with it. Whereas if you're 28 and you have an untested blast, that's going to give you about a 40% chance of getting pregnant with it. So, the number, you're cutting it in half. But you're also getting an embryo that's going inside of you where it has a chance to grow. Now, there are some practices that will not, under any circumstance, transfer to you a day 3 embryo. Everything grows to blast. They don't do day 3 or cleavage stage embryo transfers because they report their numbers and they want to be able to show an artificially high success rate. And so they only want blasts, things that are going to have a higher probability of being transferred. And there are some people that say, well, why would you want to put an embryo in you if there's a chance that it's not going to grow? And I certainly understand that position. And we can work with however you feel. But if you ask for our advice at CNY, we're going to say limited in the number, like 4 or fewer embryos, either freeze or transfer on day 3, as opposed to growing out to blast. I see Equestrian says you received 24 eggs out of 15 follicles for me on Friday. Oh, thank you. Thank you. We try hard here. 23 were mature and 20 fertilized as of Saturday morning. Wow. What would your best guess be on how many blasts we might get? Well, that is a very good question. So again, that too is really based on it's based on age, and I would say that in your 30s, for instance, of what we retrieve, about 70% of what we retrieve are going to fertilize. All right, so what do we get? 20 fertilized. Okay, so you had a little better fertilization rate there. That's pretty good. Then of those, about half of them, about 50%, are going to make it to day 3. Now, it may be a little bit higher than that. So if we said that 20 fertilized Saturday morning, so I would say day 3 embryos, probably going to be about 10 of them. And then in your 30s, I would say about 50% of those would become blasts. So probably about 5 would roughly be my guess. And that's just kind of generalizing things. So that is awesome news, man. Ariel says, I just got all my medication for my egg retrieval. I got liquid fish oil. How would I give myself that since I'm not a medical professional? Liquid fish oil. Well, it may come with a, so fish oil is a supplement. It may come with a dropper. Usually it's in a little capsule that you swallow, but usually you take that dropper and you put some drops of it in your mouth. But that's pretty interesting. I'm not sure that I've seen liquid fish oil because I would think that the taste might be enough that it would keep you from wanting to do it. Just guessing. Natalie Foster, what does prednisone do for the transfer process? I don't like taking it unless I truly have to. And I don't blame you because, usually kind of if you start taking prednisone, in the beginning, you probably feel pretty good. You get a little boost of energy. You start to feel good. And then after a little while, it starts to make you, kind of not feel as good. Really what it's trying to do is that it's, it's trying to suppress some of the immune response, pardon me, that's happening at the level of the endometrium. It's trying to stop your body from doing something autoimmune wise to block your pregnancy from being able to implant and grow. Is prednisone a deal breaker? No, it is not. It is not a deal breaker. Now, in a retrieval cycle, sometimes the steroids, the corticosteroids like prednisone, can be helpful in getting you to produce an egg, and so we will do that. That's one of the reasons that we do that. Not so much because of something autoimmune, but really just the way your cortisol levels work and how the prednisone interacts with that. There are some people who don't feel good on prednisone, don't want to take it, and I will say that's not a problem. There are many practices that don't do that at all. Skittles says, I am on a break now after 2 failed transfers, and that's a tough place to be, isn't it, Skittles? Because you really have to think about the damn roller coaster you're on here. And what I say is it's definitely an unpleasant roller coaster. The people who hop on this IVF ride and take one scoot around the track and then get off the ride with a baby are very, very lucky. For most of us, it's a lot of up and down. It's a lot of going up and a lot of going down and a lot of twisting and turning. And this roller coaster bangs your head on the back and it hurts your neck and it makes you nauseated. And what you got to know is that eventually you're going to ride that train into the station and you're going to get off of it with a baby. So it's a tough process. Stick with it because, like I always say, tomorrow is a new day. The sun rises There's new clouds in the sky. There's new wind in the air, and everything's different. So we don't know what's going to happen. Hopefully, everything changes. There is new hope for tomorrow. Let's see what we got here. Jess Gayton says, you are doing my embryo transfer next week. I'll be on day 19 of my cycle, autoimmune, antiphospholipid syndrome, and endometriosis. I hope this transfer goes smoothly and can't wait to meet you. Well, Jess, we are looking forward to having you here in Colorado. That is awesome. Amanda says, I am a new patient starting my IVF journey in Sarasota. Awesome. I have severe endometriosis and had multiple ablation surgeries. Any tips for my first appointment? Okay, so you say ablation, and I just want to clarify there. There's two different ways surgically that we can treat endometriosis. We can use an ablative technique, which is where you basically cauterize that endometriosis in an effort to destroy it, or you can excise it, where you cut that endometriosis out. So two different ways of treating endometriosis. So first of all, Amanda, I would say, there are a few supplements, 7 supplements that I recommend that you be on that are part of the evidence-based protocol. That's in my little link there, Linktree, linktr.ee/RandyFinkMD, or see the bio on my Instagram page. And there's a little ebook for $7 that even includes discount for list of those vitamins. And so that's probably the most important thing I think you can do when starting treatment for IVF. If you have that history of endometriosis, we do recommend that you double up on the vitamin C. Did you know that? If you have endometriosis, we want you taking 2 of the vitamin C capsules, which is usually 2,000 milligrams of vitamin C a day. How do you determine if you can do a modified natural, or a medicated FET? You pretty much just have to ask for it. I like to say, do you have periods, or can we make you have a period before, saying, hey, let's do a modified natural cycle. If you just call the team and you say, okay, I'm ready to start my FET cycle, the default is going to be a medicated cycle, because that's what they've done in IVF for 40 years. There is plenty of data on it. We know how to do that. We can control every variable, and there's nothing wrong with it. But if you'd like to do a modified natural, really just have to ask for it. Michelle says, can you explain ureaplasma? It got tested and it came back positive, but they didn't really explain it, just put me on antibiotics. Well, so I got to say, ureaplasma used to be kind of a bigger thing. We don't really test for it so much anymore. There's 2 different types of bacteria, mycoplasma and ureaplasma. Both of these can live in the cervix and can be associated with getting an upper genital tract infection. What does that mean? That it can move from the cervix up into the uterine cavity and can cause chronic endometritis, or can cause an infection in the fallopian tubes. It is considered to be sexually associated. It may or may not be sexually transmitted. So usually what happens is that we treat you, and we also treat your sexual partner, because we want to knock it out of both of you. Now, sometimes then we test for it again, and it may still be positive. Why is that? Because some people are just colonized with it, that in fact it's not an infection per se, but rather just a colonization. That bacteria is just kind of living with you there and doesn't want to leave. But if you've been tested for it, we definitely treat it, and we usually also treat a sexual partner. And usually it comes from another person. It is not the same thing as having something like chlamydia. It's not a sexually transmitted infection like gonorrhea. Those things indicate, well, there may have been some bad choices made, but much like I say that HPV, the human papillomavirus, is sort of the common cold of the vagina, ureaplasma is just a hanger-on. It's not really something I attach too much significance to. Liz tells me I am 33 weeks pregnant. Thanks to you, Dr. Fink. Oh, that is so awesome. Be coming back after all recovered from this pregnancy. That is such happy news. God, we love to hear that stuff. Thank you. Erica says, just had my egg retrieval last week with you and excited to hear how many embryos I have. Me 2. Chef Blackney says, what protocol would you recommend for someone with an AMH of 0.25, a mini or a regular? Well, without knowing a lot more information there, Chef, I would say, in folks who have a lower ovarian reserve like that, so that AMH of 0.825, we used to think that you want to put as much medication on the ovaries as you can in order to try to get them to respond. Well, what we learned is that higher doses of medication are not better medication, that oftentimes the ovaries will just kind of quit responding. They don't know what they're supposed to do with all that stimulation. So, if that's the situation, then, well, what happens if we crank it way down, if we go to a mini dose? So, mini dose typically is what we will look at first as a thought here at CNY Fertility. There's also an option of kind of doing an age appropriate dose. We tend to steer away from the very high dose therapies because they're very expensive and they really don't work very well. We tend to go less is often more. So they're probably a mini dose. I would think. Let's see if we can get to one more over here. McCrae Hines says, do you recommend an immune protocol for Hashimoto's? Hashimoto's thyroiditis is autoimmune thyroiditis. Thyroid gland lives in here. And we can tell from doing a blood test whether you have an inflammation in the thyroid gland as a result of your immune system attacking your own thyroid gland. And that's what's called autoimmune thyroiditis, or as we say here, Hashimoto's. Yes, I do think so, because if you are being treated, if you have Hashimoto's, that tells me you've got an inflammatory state. So I definitely want to try to suppress that. And I usually will use Immune Protocol 3 for folks with Hashimoto's. I also, with Hashimoto's, like to keep your TSH hormone level at around 1. So I'm much more apt to think about giving you a little bit of thyroid medication to get you there. Folks, we are going to be out of time this afternoon. Boy, we always run out of time here. It happens so fast. Thank you so much for all your questions and all your support. Just being here, it's a special place to be every Tuesday afternoon at 4 o'clock Mountain Time, which means 6 o'clock on the East Coast and 3 on the West. And I hope you'll join me again next week. Remember, this whole business, it is not the book of your life. It is merely a chapter. And what are we doing? We are here to rewrite that and to do it together. Lead forward every day with love. There is not enough love in this world. There is not enough kindness. Please perform some random act of kindness, even if it's just to say hi to a stranger when you pass. And you know what? You will have done something very positive for the world by such a very simple act. And know that each day is a new day for hope, that no matter what happened to you today, tomorrow starts all over again and gives us all a new chance. So until next time, I'm Dr. Randy Fink in Colorado Springs. Thanks so much for being here, and good night.